Uh, Good evening, my dear students. In this video, I am going to discuss about the changing nature of the Surviving Sepsis Campaign guidelines. And these are absolutely my views based upon these guidelines, that from rigid protocols to personalized pathways. Now, why are we talking about this? Since its launch in 2002, jointly by the Society of Critical Care Medicine and the European Society of Intensive Care Medicine, the Surviving Sepsis Campaign guidelines have evolved dramatically. Although initially they were designed to reduce the global sepsis mortality through standardized care bundles, then they took a turn. They have transitioned towards evidence-based flexibility. They have transitioned towards context sensitivity. And today, when we talk about the guidelines, we find the angles of personalized medicine peeping through them. Now, this transformation reflects both changing landscape of critical care medicine and also our deeper understanding of sepsis as a heterogeneous syndrome and not as a single entity. Over 2 decades, new clinical evidence, implementation challenges, and global inequities have reshaped both the philosophy and the practice of sepsis management. If we look into the evolution of the Surviving Sepsis Campaign, we can broadly divide the phases into 3 phases. One, a early phase where the primary concern has been, or the primary goal approach has been, standardization and the bundles between 2004 to 2012. Then came the middle phase where the goal was bundle refinement and simplification. We can take it as from 12 to 2016. And the recent phase, that is from 2018 till date, if you look, it is primarily all about the our one bundle and individualization. Let us go at a bit at length. In the early phase, which we can say as standardization and bundle phase, that is 2004 to 12, we see that the early guidelines sought to standardize the care globally by defining strict timelines. They were the 6-hour resuscitation, the 12 to 24-hour management bundles, etc. And these emphasized early antibiotics, aggressive fluid resuscitation of more than 30 mL per kg, greater than equal to lactate measurement, CVP guided therapy. The philosophy was straightforward, that time is tissue. And evidence at that time was primarily derived from the reverse early goal directed therapy trial, so which suggested that prompt and protocolized interventions could markedly improve the outcomes. Hospitals that implemented bundles often demonstrated reduced mortality, but at the cost of rigidity and resource strain. And this was felt more in low resource settings. Then we look into the middle phase. This was the phase of bundle refinement and simplification. This happened because by 2012, emerging evidence challenged the validity of and the universality of early goal-directed therapy. Large multicenter trials like the Process, Arise, Promise, they failed to reproduce the dramatic benefits which early goal-directed therapy had shown. And consequently, the Surviving Sepsis Campaign 2016 guidelines softened their stance on fixed targets like CVP and SCVO2 and replaced them with more flexible goals such as dynamic assessments of fluid responsiveness. Bundles remained central, but clinicians were urged to use clinical judgment rather than mechanical obligation or mechanical adherence. Then we come to the recent phase, that is from 2018 onwards. We find the Hour One bundle and individualization has been the hallmark during this phase. The 2018 Hour One bundle attempted to compress the golden window of care, recommending that key interventions like lactate measurement, blood cultures, antibiotics, fluids, vasopressors be all initiated within 1 hour of recognition. Now, this generated substantial controversy because many argued that time-based mandates ignore diagnostic uncertainty and local resource constraints. So we tend to overtreat. A rigid 1 hour rule would lead to antibiotic overuse. They will lead to unnecessary fluid loading, especially in patients whom later may not be found to have sepsis at all. In response, in 2021, the Surviving Sepsis Campaign guidelines adopted a more nuanced tone. The need for urgency was reaffirmed, but flexibility and context were explicitly acknowledged. So, what happened was that recommendations became more graded, strong versus weak, and transparent about evidence quality, which reflected a mature recognition that sepsis care cannot be reduced to a stopwatch driven algorithm. So, what are the thematic shifts in this set of changing guidelines? We have to identify point wise. The first is that from one size fits all to personalized sepsis care. This has been the most fundamental evaluation in the shift towards individualized therapy. Sepsis is increasingly understood as a spectrum of dysregulated immune responses influenced by host genetics, microbiome, comorbidities, and infection source. And there are a host lot of other factors too. So, Surviving Sepsis campaign now emphasizes phenotyping and dynamic reassessment using clinical, hemodynamic, and biomarker data to tailor fluids, antibiotics, and vasopressors. So, while bedside tools like lactate clearance and capillary refill time remain practical, emerging concepts like sepsis endotypes or transcriptomic guided therapies are shaping the future of the therapy. So, this personalization represents a paradigm shift from protocol driven uniformity to precision guided adaptability. Second, rethinking fluid resuscitation. Early Surviving Sepsis Campaign guidelines mandated at least 30 mL per kg of IV crystalloid within the initial hours of sepsis. However, accumulating evidence showed that excessive fluid can worsen interstitial edema, can impair oxygen delivery, can exacerbate organ dysfunction. So, recent guidelines recommend balanced crystalloids over NS, supported by trials like SMART and SALT-TD. And the 2021 SSC explicitly acknowledges that 30 mL per kg rule is a weak recommendation and it should be guided by fluid responsiveness rather than blind volume targets. So, point of care ultrasound, passive leg raising testing, dynamic indices like PPV are increasingly encouraged, marking a turn towards physiology guided resuscitation. Third, antibiotics and the dilemma of stewardship. Early Surviving Sepsis Campaign iterations demanded antibiotics within 1 hour of recognizing sepsis. However, subsequent evidence revealed that while delays correlate with mortality in shock, indiscriminate antibiotic use drives antimicrobial resistance and Clostridium difficile infections. The 2021 guidelines recommend that antibiotics be administered immediately in septic shock, but it allows up to 3 hours of clinical assessment in non shock patients if diagnosis remains uncertain. So, this marks a subtle but important shift from compulsion to contextual judgment, aligning sepsis management with antibiotic stewardship. Fourth, beyond macro hemodynamics, looking into the microcirculation. Now, traditional resuscitation has always focused on restoring macrocirculatory targets, MAP more than 65, urine output, CVP, etc. Yet many patients, despite achieving these goals, continued to exhibit tissue hypoperfusion and organ dysfunction. So, the new focus is on microcirculatory and endothelial health, addressing glycocalyx protection, oxidative stress, and myocardial dysfunction. So, although majority of the therapies still remain experimental, the Surviving Sepsis Campaign's language now recognizes the limitations of pure hemodynamic targets, inviting future integration of cellular level interventions. Fifth, the post sepsis continuum. Early guidelines concentrated on acute survival. Recovery was an afterthought. Today, the Surviving Sepsis Campaign acknowledges that surviving sepsis is not the end of the story, it is the beginning of a chronic health journey. So, post intensive care syndrome, post sepsis syndrome, encompassing physical weakness, cognitive decline, depression, recurrent infections, which affects up to half of the survivors, finds place. The latest Surviving Sepsis Campaign recommendation emphasize rehabilitation, follow-up, and care transitions, echoing the broader movement towards survivorship-oriented critical care. And lastly, globalization and adaptation to low resource settings. The Surviving Sepsis Campaign's early guidelines were often criticized as Western centric, assuming advanced monitoring and rapid laboratory access. But that was not possible in all places, all geographical locations. Recognizing this in WHO in 2024 and Global Sepsis Alliance, they have released complementary frameworks focusing on feasibility, simplicity, and tiered care in resource limited settings. The 2021 Surviving Sepsis Campaign incorporated low resource adaptations, for instance, allowing clinical rather than lactate based diagnosis when lab access is limited. The emphasis has shifted from ideal care everywhere to best possible care anywhere. And this democratization of sepsis management represents one of the campaign's most socially impactful evolutions. So, why are these guidelines changing? One, primarily because the evidence base is expanding. Continuous research has exposed the limitations in prior dogmas. Second, recognition of heterogeneity, as we have already told that no two septic patients are alike. Age, comorbidities, immune state, infecting organisms, they all create immense variability in the trajectory and treatment response. Three, the problem of implementation. Implementation studies reveal that rigid bundle compliance did not always correlate with survival, especially in smaller or under resourced hospitals. Fourth, rise of stewardship and safety concerns. Growing awareness of antimicrobial resistance, fluid overload syndromes, ICU acquired weakness necessitated a balancing of priorities from treat everything fast to treat wisely and safely. And sixth, survivorship and humanization. The pandemic COVID have pushed guidelines towards holistic sepsis care, addressing not just survival, but also looking into dignity, communication, and rehabilitation. However, some controversies still persist. These include the time-based mandates. Should 1 hour targets remain in performance metrics? Many clinicians argue that rigid timing penalizes thoughtful care. Fluid volumes, the 30 ml per kg rule persists despite weak evidence. Individualized titration is conceptually appealing but operationally difficult. We all know that. Screening tools, QSOFA versus SIRS versus NEWS, all still remains unsettled. Adjunctive therapies, vitamin C, corticosteroids, novel immune modulators, they give conflicting data. And equity and access. Can guidelines be truly global when health systems are so unequal? We have not been able to find this answer. So, these controversies highlight a healthy tension between scientific evidence, clinical pragmatism, and ethical realism. So, what to expect next? The next decade of Surviving Sepsis campaign will likely focus on precision medicine or precision medicine sepsis. The key directions would include one, endotyping and biomarkers using genomic, proteomic, and metabolomic signatures to tailor therapy. Artificial intelligence and predictive analysis integrating electronic health record based sepsis prediction tools to enable earlier recognition without overwhelming clinicians. Three, therapeutic de-escalation models, algorithms to safely shorten antibiotic duration and fluid therapy. Four, global adaptability, development of scalable sepsis bundles for rural and low resource hospitals. And five, patient centered outcomes, greater emphasis on long term quality of life, functional recovery, and patient and family experience. So, my final take home message would be that the Surviving Sepsis Campaign journey reflects the evolution of modern medicine itself, from standardization to sophistication, from rigid algorithms to adaptive intelligence. Each iteration has moved closer to the reality of bedside practice, that sepsis is not one disease, and that survival depends not only on speed but also on appropriateness. The changing nature of Surviving Sepsis Campaign guidelines thus represents not instability but growth, a continuous calibration between evidence, ethics, and equity. In future, success will depend on embedding learning systems, training adaptable clinicians, and ensuring that every patient receives timely, intelligent, and human care. Thank you.